This is an instructional video on how to present a new patient admitted to the medical intensive care unit.
We have a 72-year-old female with past medical history of hypertension, hyperlipidemia, CKD, HFpEF, and diabetes mellitus who presented to the ED with 3 days of cough, fever, chills, and myalgia. In the ED, patient was initially febrile to 38.7, tachycardic to 110, satting initially in the 90% and then became more hypoxic with increased work of breathing to the 28, and hypertensive to the 160s over 105. Labs were initially remarkable for a BUN of 40 with a creatinine of 1.8, NT-proBNP in the 2500, TROP negative, and a small leukocytosis at 12. UA demonstrated a few leukocytes, 11 to 25, and chest x-ray demonstrated bilateral multifocal infiltrates. Patient, given increased work of breathing and hypoxia, was subsequently intubated in the emergency department and then transferred to the MICU. In terms of pertinent medical history, patient has a history of hypertension, hyperlipidemia, diabetes, CKD, and HFpEF. Only prior surgeries include an appendectomy. In terms of social history, patient family denied history of smoking, alcohol use, and illicit recreational drug use. In terms of family medical history pertinent for mom with hypertension and diabetes, no other pertinent medical history. In terms of physical exam, patient is currently intubated, sedated, afebrile after Tylenol given in the ED, tachycardic to the 110s, hypertensive to the 150s over 110s, and then respirations in the 28s. In terms of respiratory, she's intubated, mild coarse crackles bilaterally on exam. Cardiovascular, she has peripheral edema 1+ on exam, as well as tachycardia but regular rhythm. No other pertinent medical exam findings. Labs were significant for a leukocytosis of 12, NT-proBNP at 2500, TROP negative, and a mild anemia at 9.7. No transaminitis or other medical relevant labs on exam. Imaging demonstrated bilateral multifocal infiltrates on the chest x-ray as well as on the CT chest. So for our assessment and plan, we have a 72-year-old female with hypertension, hyperlipidemia, CKD, HFpEF, who presented with cough, fevers, chills, and increasing hypoxemic respiratory failure, status post intubation in the ED, and transferred up to the MICU for further evaluation and treatment. So for neuropsych, we have patient is intubated, sedated on propofol and fentanyl for a RASS score of 0 to -1. For cardiac, we have decompensated HFpEF, echo demonstrated an EF of 50 to 55% with grade 2 diastolic dysfunction. Patient is started on Lasix 40 milligrams IV for diuresis. Hypertension, we started amlodipine 10 as well as carvedilol 12.5 milligrams BID. For respiratory, we have acute hypoxemic respiratory failure secondary to influenza A as well as a concern for secondary community-acquired pneumonia. We started the patient on Tamiflu for 5 days, as well as ceftriaxone and azithromycin. Blood cultures and urine cultures are still pending. Legionella and strep urine antigen were also sent. For the pulmonary edema component, we started the patient on Lasix 40 milligrams IV BID. We'll continue to monitor for renal and urine output. For infectious disease, like we talked about above, we have community-acquired pneumonia as well as influenza A. We're continuing the antibiotics and the Tamiflu, and we're following up our blood cultures and urine cultures. For hemonc, we have a mild normocytic anemia at 9.7, transfused for hemoglobin above 7. For GI, no acute issues at this time. For endocrinology, we have a history of diabetes mellitus. We're holding her home PO hypoglycemics and starting a medium dose sliding scales for goal 140 to 180 in patient. And then lastly, we have our checklist. For feeds, we placed an NG tube and we'll start Glucerna 1.2. For fluids, we're holding off and we're actively diuresing the patient. For activity, she's intubated in sedation. For DVT prophylaxis, we had started heparin sub-Q TID. For GI prophylaxis, we're starting famotidine 20 BID. For glycemic control, she's on a medium dose sliding scale. For bowel regimen, we can use Doxena PRN, and then for lines, tubes, and drain, she has an ET tube, NG tube, and 2 peripheral IVs. For drips, we just have fentanyl and propofol.